This is supposed to be our Q&A session. This is for our community to come and share, ask questions. I always say, bring your questions, bring your insight, bring your enthusiasm. We are continually working on a community platform, but for now we're using this platform. But the marketing that we put out, solicitation, was like to have a conversation around glutathione. And that's what I'm prepared to do. And I bet a lot of you have joined us because of that, and you might be interested in glutathione. Many of you might have already been doing glutathione or have been doing glutathione for years, whether that be oral or IV or other ways of doing it. You can nebulize it. And so if you've got any insights and experience, things that you would like to share there, we would love to hear all that from you. So please get familiar with the chat. Write your questions in there. Last month, I was stumbling a little bit without my team to help me figure out how to allow people to speak. But Lexi, you was talking about some marketing pieces to Procaine. We were talking about Procaine a lot. And we also had, some other voices that we heard in terms of questions. So I did also want to talk about the saline crisis or the IV bag crisis and get some feedback on that for our group that's here tonight. So you can already start using the chat, start writing in your questions. And again, it could be anything from ozone and UV to EBU to Procaine to glutathione to IV regulations. I just spoke with Ava on Friday. Hopefully a lot of you were there. The American IV Association, and their focus is on regulatory and compliance in terms of just IV spaces. And so that was super insightful. I spent almost the whole 3 hours there. I spoke for just about 30 minutes, but it was about 3 hours long, and learned so much and had just good reminders about compliance and regulations that they tend to focus on. So if you have questions about that, the marketing, the sales, just any of it. And again, I don't need to be the center of the platform here. I would love for any of you to be able to share your expertise to any of the questions that are asked. So welcome to MedMasters Community Mastermind tonight. Appreciate all of you. We recognize so many of your names, and these days I don't get to recognize everybody's names. It's the sad part about growing and expanding, even though there's so many good things to it too. But still appreciate you for being here and participating and being the providers that you are, that want to do better and want to provide good medicine to your patients. We definitely feel like we are in partnership with you. We couldn't do it without you, but we're here to serve you in the ways that you need most. So again, the two main topics I thought about bringing up, outside of any questions you all may have, are this shortage or allocation that we're facing due to the hurricane that hit South Carolina. In terms mostly, I think, of IV bags, saline definitely, sterile water also. And so we've had a lot of questions around that, and I've done some work. I've tried to do a little homework on it so that I could offer you some things. One of the questions tends to be like, how do I preserve what I have? And so I'd love to, again, hear from you guys. If anybody knows of a supplier, if anybody has ideas on ways that they've done this, anybody has any intel on how long this is going to be. I thought that it was just that the main thoroughfare going in and out of the warehouses was down. Not that that would be easy and simple to fix, but it actually turns out that the roof was actually destroyed. And so it might be a while. So I've written down a few notes here. Let me change screens too, so I can see what you guys are writing. All right. Ginger, thank you. So I do know that they're on allocation, right? And you may know what that means, you may not. And every company, I just talked to a McGuff an hour ago, and he says every company kind of does this a little bit different, but the allocations are first going to go to the emergency, hospital type facilities. And even locally, I've got 3 hospitals locally, and one of them is not even getting what they would like to get. So even those larger emergent facilities have been kept in rationing in some cities and some states. which tells you, I guess, to the degree at which this is an issue. But McGuff, yeah, I like that. Sean, you're writing McGuff has 500 ml bags of normal saline. What they've told me is they allocate based on your previous order. And so they already had you on allocation based on your order history. You may or may not have known that. And so they, again, allocate what they think you use based on your order or usage history. And so if you didn't have an account with them, or if you had an account, but you weren't using it with McGuff, they probably lowered your allocation and you can only get so much or less than that. However, and this happened to me last time that we had this shortage, with what was it, tsunami in Puerto Rico or something. The same thing. If you call your rep and you say, I need some IV bags, they will, at least with McGuff and the other companies that work in terms of this form of allocation, they will in fact go through their accounts and they're local, right? They're local reps, but they'll go through their accounts, excuse me, and they will look at anybody who's allocated, let's say 4 cases a month and doesn't use their 4 cases a month. And then they will take that and they will give it to somebody who asks for it. So again, I just did this an hour ago and I got 6 cases shipped to me because they went to other places that either no longer do IVs or hadn't ordered in a long time, but they were allocated that much amount, but they weren't using it. So that's one way to get into that if you can or can't get anything from the website. The other thing I've been told, at least again in certain locations, is that they were allowing you to order a certain amount every day. Then they push it out to every week. You can only make 1 order a week. So you always at this point want to buy everything that you can in the moment. And then, because you never know what's going to happen in the next moment, but they're still limiting the amount and times that you can do that. And that's for normal saline and sterile water. It appears, and again, tell me if this changes for any of you, but the question was lactated ringers. So can we use lactated ringers for, let's say, ozone and UV procedures? Yes, you can. Obviously, just like the normal saline or 0.45 saline, you need to be aware of your patient's scenario and condition. If LR, the osmolarity, or the formulation, or 0.45, 0.09, if they are not appropriate for your patient, you then don't use it. But in terms of, can you add blood to it? Can you add ozone to it? Can you run that through UV light? Yes. So trying to find your LR is also another option. Dextrose, I've only tried it a few times. It can work. Again, does everybody want to be giving dextrose to their patient? That's the real question, but it can work with ozone. It does work with blood. I don't see any issues with putting any heparin in it or sodium citrate, whatever anticoagulant that you're using. So you may choose a variety of different infusions now that you may not be able to get exactly what you want. The next thing is the sizing, right? So like today I had a local clinic, or not a local clinic, I had a client who she found some sodium chloride from a company called ciamedical.com. I'd never heard of this place, and I haven't had time to vet it out entirely yet, but they had liter bags for about $8.80. She was able to get 6 cases of it. And I was like, okay, great, get it. But a liter is a lot. You don't, most of the time, we don't need a liter for any one procedure. And so even if you're getting 250 bags, 500 bags, liter bags, one of the questions is how can we preserve it? So I thought of a couple different things here. One is, normally with the standard, let's say O3 UV, you are draining the bag down to about 160 and you're leaving about 30 mLs in the tubing and then you're getting rid of about 60 mLs. Well, instead of letting that run down the sink or in the trash, just pull it out in a syringe and reuse that saline, right, for your IV pushes, for mostly IV pushes. But the other thing is if you do high dose also, I do this all the time. Vicky's seen me do this 1,000 times in our conferences, is I will draw that 60 mLs out, and then that is what I use for my high dose. So you need to have syringe, right? If you're doing high dose O3 UV with the infusion pump, the syringe pump, and that's only going to apply to some of you, but if you're doing that, then you can draw off that bag for your standard and turn around and use it to prime your bags and your tubing for high dose. Another, like again, when we travel, there's only so much we can take. We want to be able to do as many therapies as possible. So I've been using robbing Peter to pay Paul with the saline there. And that way we don't have to carry as much. So that's another idea if you do both of those procedures. The next thing is like do pushes instead of IVs. So any case like a procaine, like a glutathione, even Myers cocktails, poly-MVA, NAD even, there's ways to do IV pushes that would require a lot less product and yet still give your patients some of the benefit of the IV protocol or the IV concept, right? Intravenous. And that's going to take a different formulation or recipe, right? Like, you know, you're having less saline there. So the dosage of glutathione, procaine, poly-MVA, Myers cocktail, whatever will be less. You need to know how to do that math and how to, you know, make sense of that. But that's another way to do it. You can keep doing these great infusions. They may not get the same volume, but it still is an IV using a lot less saline. And then you can do a multi-dose puncture from your IV bags, especially if you're getting like 1,000 mils. Because empty bags might be, I haven't checked into that a whole lot this time, but last time this happened, those empty bags, they sold out so fast because everybody was taking a liter bag and making 2 or 4, you know, other bags with it. And so that won't last very long, even if it's still available, but that's also an idea if you can get, they were always really expensive. Those empty bags were a lot more expensive and they use it for phlebotomy, right? Like they do it for blood donation and different things. But if you could find those, that's also another way. When it comes to ozone, I was thinking about, you got your IV nutrition, and I'm thinking do pushes. You've got your ozone, and you've got your photobiomodulation or ultraviolet blood irradiation aspects to IVs. With ozone, keep in mind the ways that are that are going to use less saline are insufflations. So rectal insufflation is a systemic therapy. It's a great way to get ozone into the body without an IV. We've always used that as, you know, for people who don't have veins, who don't have the finances for IVs. And so if you're not doing insufflations now, it's a great time to implement those and learn that because you won't need saline for that. So it's actually, if you're interested in that, we teach that. We can definitely optimize that for you. Just put in the chat insufflation and we'll make note of that and we can reach out to you and offer those classes. If we can get enough interest in these and kind of put everybody in one class or 2 classes, then we'll totally teach an insufflation class. We've got an all things ozone class already, but we could, it's a great time. You already have the ozone generator. So start doing more of these insufflations. It's a great systemic therapy. The next thing is to do direct IV ozone. I'm really curious. Is there anybody on that does direct IV ozone? Especially if you're getting Canadian bags. In Canada, they've allowed this in certain districts. But yes, we are recording this for later. I just saw that from you, Jessica. Direct IV ozone, I have stayed away from teaching, and there's reasons for that. And I am not a provider who would want to do a real great clinical assessment and overview of it. Ozone's ozone, we know that part. But doing direct IV ozone is different. I have been trained on it. I've performed hundreds of them. I did one on myself last week, the week before. And so it is a concept that might be worth exploring in light of the shortage. So also with this, if you're interested in even just hearing me talk about that, what that looks like, what those protocols would be, then put DIV in the chat. We'll make a note of your name and we'll reach out to you if we get enough interest in that to just, again, hold maybe a webinar exclusively around that. So those are 2 ways to do ozone without saline. You also could do just a typical MAH. The original major autohemotherapy did not require saline. You drew whole blood, added ozone to it, and put whole blood back in. However, where are you going to get the bag to put the blood into? So you still need some sort of IV bag, and in that case, it wouldn't matter what you were getting. You would empty the whole thing out and just put even sterile water, right? You could get a sterile water bag, drain the whole thing out, and then use gravity to draw blood into the IV bag, add ozone to that, and then reinfuse it by gravity. So there's 3 ways that you could do ozone. When it comes to the photobiomodulation, that is the part, if you don't know this already, that is the part that requires or where the saline is actually utilized. And that means the reason why is because if you use saline, you don't have to draw as much blood because it's kind of it's been, oh, what's the word? Anyway, the mixture means that you don't, it allows the same amount of light to reach the blood adequately. I could not think of a way to do the blood through ultraviolet light without the saline. You could do it just like major autohemotherapy. Just know that a lot of the blood that you run through that UV light, especially the champion, is not going to receive a lot of light. We know it's 1% of the blood that goes through the cuvette in a champion device is getting exposed to the light with that saline mixture. And it's about the same with whole blood actually too. But you'd have to, you'd have to draw the full 250 mils of it to get that same 1%. And if that's not making sense to anybody who's really interested, then let me put that in the chat and I'll explain that. If you have a hemolumen device, that is a little different. It's got more power. It's got a trivet, so the cuvette goes through 3 times and it's got extra double bulbs and stuff in there. So that's generating more energy. It's got to 3 times of a cuvette. So there would be more blood probably receiving more light even. And they don't even really use a lot of saline. So, you could kind of make some adjustments there also. But just know that it may be a little less blood, or you still have to find that bag. You still have to have the bag to put the blood in. But it doesn't have to be saline LR. It could be the sterile water. But the other way to do light without, this is another great time to maybe look at, I started last week Shiny Gadgets with PEMF. The next one next month is going to be on photobiomodulation, uh, 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 localized, on the skin. What is the word? I can't think of it. Devices, right? So they've got them for the face, the head. You can put them on any body part. And they've even now got them for the wrist. And the wrist is not for the wrist. It's just that this is where it lights up the circulation as it runs through here, the arteries and veins here. And then that light exposure is actually passing by your veins, normal circulation without any IV. And these devices have become very, very powerful, very affordable. And I really think they're fantastic ancillary devices to your IV room, even when we can get saline and all the fluids that we want. So I was going to talk about it next month anyway. Just like we talked about PMF last time, it will make every IV better. It helps with hypercirculation, helps decrease pain, helps inflammation. And again, you can localize it, but there are devices where you could use it for systemic, if for some reason you're just not able to do as many IVs. And so there's, again, maybe pick and choose which IVs need to have the saline or have the IV bag, which ones could be without, which ones could be just pushes, and then what maybe some of these other things are that you could do if you don't have, you can't do the IVs at all. So there's what I have on the saline crisis. Yeah, Vicky put in there the CIAmedical.com. Again, I have not vetted that out. I know when this happened before, people were getting non-sterile bags or expired bags and not realizing it through companies who were exploiting the situation. I actually know 2 providers who got really, really ill because they did not get good saline. They thought they were, and made them very, very ill. So I have not vetted this out, but I do know that company, I'm looking right at it, they've got 250 bags of sodium chloride. And then check with your McKesson, Medline, McGuff reps and see if you can't borrow from some of those others that never have used it or don't use it or aren't using it. All right, some of your questions. Sean, thanks. I purchased from Canadian Medical Store on the 15th. Is that what it's actually called, Canadian Medical Store? I've reached out to some much higher powers that be here to look and see what other distributors we might be able to go to even outside the country, and just haven't heard a lot back yet. I know that they exist, but it's just put a lot of stress on them, and still in the US they're rationing. So 2 to 3 weeks from McGuff today, Bree. Yeah, and you really just have to be diligent and just keep checking back and see what you can order, and order as much as possible. But still, we don't know how long this is going to last. So I still think you want to be very careful and selective with what you do get. What is an average dosage of ALA infusion for neuropathy? Diluted in how much solution? ALA alone, I have not used in quite some time. I prefer poly MVA. And that's just to be transparent with what my more recent and probably the last 10 years of experience is. I haven't used ALA alone. So I could look this up and I could tell you what I used to use. I wouldn't want to throw anything out there in case I'm wrong, because it's not at the top of my memory. If you don't know about poly MVA, it's another course that's coming. I did record a podcast with the son of the founder. There's a collaboration there. I don't want to misstate, but the owner now of poly MVA, and it's an alpha lipoic mineral complex proprietary blend with thiamine. And so that's my preferred, because it's a balance. Not only, we talked about this in the podcast, is, it takes a team of players to make cell function be optimized. And when you have all the players together, the game goes better. And so alpha lipoic's one of them, vitamin C is one of them, right? Like, we can isolate these things. What I love about the proprietary blend is they put it in the right combination to kind of have many of the players of the team in one, again, proprietary blend. The other reason I love it is because it's one draw. So when you talk about pharmaceutical compliance and et cetera, it's really nice to have one ingredient IVs. And that's the other reason I love poly MBA. And I can give you the dosages on that. But again, it's not just alpha lipoic acid, although that is a part of it and a piece of it. Marlis, if you want to email us, I can definitely look up that information and get back to you. And if anybody else has any information they want to share with the ALA, it's a little bit temperamental, ALA is, and that's why I like this blend that helps the medicine go down a little bit better. Bridget, I have a very specific patient-related question. I would like to know if there are any contraindications to starting ozone IV therapy on a 66-year-old with long-term polycythemia with, sorry, my eyes just went a little I can't say it. Normal platelet count, but elevated CBC, RBC, and HTT. Any input would be appreciated. Thanks. If there are any other providers, I'll go to providers first who have some, any insight to this. The spleen, normal platelet count. I don't see any contraindications looking at that at a glance. I would, however, say start low and go slow. And maybe, have you gotten a G6 PD on her, would be the only other thing I mean, if platelets are good, RBCs are good. I don't think that's going to be a problem. But again, you'd want to start with a really low dose and maybe even concentration. So there's a difference. Had a conversation with a client today where they were like, we see such great results when we do 40 gamma. The second we go to 70 gamma, even though it's a lower total dose, they get more of the detox reactions. So I would definitely say, no higher than 40 gamma on those initial treatments and no more than 60 mLs of it. And just go slow, maybe once a week, and see how she does. Aaron, you do direct IV ozone? Interesting. Yeah, because of the religious factor, I get it. That's interesting. And if any of you who are doing it would like to participate, literally being part of the instruction, the conversation, I'd love that. I've got gobs of experience with it, but again, it's kind of been frowned upon in the US just because it appears as if you're putting ambient air into somebody's vein. And so it's the perception of it from the patient perspective and even from the provider perspective. And also, you don't get to have the light variation of it there. In this case, though, this is why I did it the other day. It's just easy on myself. It's easy, it's fast, like, but there are nuances to it that you need to be careful. You do need to be trained on it. I would not just say, oh yeah, go do 60 cc's. You need to be paying attention to patient responses there. So, yeah, if there's anybody with experience who would like to help me with that, that's great. Aaron, are you talking about the patient case we were just talking about? Do therapeutic phlebotomy prior to ozone in that patient? That's really good advice. How many, would it be like 500 mils that you would draw out? Yeah, Courtney, exactly. So the thing with the direct IV ozone is it hits fast, it hits hard. It is way different than doing an ozonated saline or a major autohemotherapy or anything. It hits hard, it hits fast. And it hit me. I hadn't done DIV in a long time, but I've done a lot of ozone in every other way, and it still hit me hard and fast. So that threshold, right? The lungs don't have the redox capacity to convert or to handle the ROS that's created because or to generate in the lung tissue anyway, the like antioxidants. And so you get that tightness in your chest, you get feel like I'm running on a cold day, you start coughing, but if you don't know when to stop, and every person's different, and again, we can review this in a more controlled setting, it can become very intense to the point people freak out, they're in the emergency room. And there are antidotes to that as well. So again, please don't just go out and do this. If you're interested in having that conversation, list it here in the comments and we'll pull together a group that wants to go through that. Bree, how long does it take typically to set up the tubing IV bag for EBU? And then how long does it typically take to run once the patient is here? I'm glad you brought up EBU. This link was initially used for our EBU Mastermind. And so our client liaison was noticing that today and was saying, hey, there's a lot of people, providing feedback to the survey for EBU. So it's interesting that we have a lot of people here that don't do EBU, haven't learned about EBU, maybe want to do EBU. And so once again, put in the chat if you're one of those people, because I think we're going to start to do like a monthly or bi-monthly course class where you can come learn about that live. But to answer your question on EBU, once you get proficient, right? When you're first learning, it's a lot. Once you get proficient, you get good at it, you're doing it all the time. I'd say the setup is 10, 15 minutes. And then the procedure, it's all about the stick. It's all about the stick, not just both sticks. It's not just, can I get a stick? Can I get in a vein? But is that vein, both those veins, going to perform? And so depending on your patient selection, how good their veins are, how prepared they are, how prepared your patient is, and then how good you are at tapping that vein. And I say that vein, one draws and one returns. So one vein is more important than the other. You can be start to finish with that whole thing. The machines actually run for 50 minutes. But everything considered, you can be start to finish in 60, 70 minutes when you get really proficient at it. And again, based on your patient selection. Now it can also take 3 hours if you don't go through all that and you don't do it well. And sometimes, a lot of times, a patient's not a good candidate for it. We've learned that, we emphasize that. Courtney's here, she could definitely speak to that. And we always recommend that you schedule about 2 hours for it. And that is, again, in case of all these nuances, making sure the patient's prepared, especially their first or second treatment. There's a lot going on. A lot of patients can see that and get nervous about it. There are some adverse events also that can happen if your patient's not hydrated, if their blood sugar is not healthy, meaning proper. And there's just things that go along with that. And you definitely don't want to feel rushed. You definitely don't want your patient to feel like you're rushed or they're rushed. And so we recommend about a 2-hour block for that to get it done and to get it done well. There you go. Less than 5 minutes for setup. Thanks, Courtney. Yeah, and if you are piggybacking anything with it, it's nice too, because you can kind of fit it all in. Oh, and she said too, yeah, agrees. 2-hour appointment start to finish, both nutrient IVs and EBU. Yeah, thanks, Sienna. DIV is great. And I feel like, again, the doctors just really need to understand the risk to it and actually the lack of risk to it, because a lot of this is just their comfort level and then helping the patient understand. Again, it's not ambient air. That's why embolism, etc., is not near the situation people assume it is. But we are a society that grew up watching ER on TV, and so people think that if they get even a little bubble or two of air in their line, they're going to die. So that's the perception is really where the risk is, but providers need to be well aware of that. So I did see a question originally about glutathione. Let me find it. What is the highest dose of glutathione IV push weekly? Would love your feedback on this. I was trained and follow still to this day Paul Anderson's protocol on this. I've also been very, very involved with creating some protocols with a pharmacist, a functional pharmacist on this, who's a little more conservative. But in all my years in administering IVs, we always did 1 gram on the first treatment, 2 grams on the second treatment, 3 grams on the third treatment. So 1,000 milligrams, 2,000, 3,000. I've never seen it come any other way than 200 milligrams per ml. So that's 5 mLs, 10 mLs, 15 mLs, right? And then a 1-to-1 ratio of that. And we'll say sterile water now, or sorry, we'll say normal saline now. Osmolarity of glutathione is actually higher than people realize. And so it can be mixed in sterile water, but a lot of people get, and I prefer that, but a lot of people get nervous about the sterile water. Even though when you add the glutathione to it, it is no longer sterile water and the osmolarity is no longer 0. So anyway, a 1-to-1 ratio there. So 5 to 5, 10 to 10, 15 to 15, and you get the 1 gram, 2 grams, 3 grams. Now, I know several providers that'll go higher than that. I don't teach that. I think you need to get your feet wet. I think you need to understand it. And I have seen just a couple in all the years. I've seen a couple people really respond dramatically to glutathione, instant diarrhea, instant vomiting, things like that. So, but once I get to the 3 grams, I'll stay at the 3 grams. And also, we do have a glutathione presentation and bundle with all the onboarding protocols. We've had a mini one on our store for the last several months, but I built it all out in the last week to have more of the materials. So I did pull up those slides and I can show you some of the information on glutathione, but it's fantastic and it's pretty universal, large scope of practice with glutathione. There is one person who has a lot of followers and really talks a lot about doing ozone and glutathione together, and she really is opposed to it. I do not share her views on that, and most providers don't, but there is a component to that. There is something to realize there. And really it's because glutathione oxidizes very quickly, very quickly. So you should not use glutathione that's been sitting around for even 5 minutes. Whoever you order your glutathione from, you should vet out how long they go in between batches that they supply to you, because they should be testing it at a great cadence, a frequent cadence, to make sure that what they're sending you has minimal oxidation, because it's at the oxidative state that it can attach as a thiol group and become a neurotoxin. And I'm not the pharmacist to explain all that. I just know that that's how it works. I can get you in touch with somebody if you want to, but glutathione otherwise can be really, really great, but getting it fresh and putting it in a push is the proper way to do it. Right now in IV rooms and these pharmacists that are putting it out in IV bags and pre-mixed and all this other stuff, fine, I would not do that. And it's, I think, where you stand on optimization and your level of excellence, right? So you do want to make sure that it does not oxidize, and that means that it is best in a push or at minimum at the very end of an IV bag. So it should not sit in an IV bag for 30 minutes while you drip it. It should be done pretty quickly. A push is the best way. And so that 1-to-1 ratio is really what I think is the best, what we have found. We as in the practitioners I've worked with and worked under had great results with that. Let's see, what else is there in terms of glutathione? Glutathione is a great antioxidant. It actually has effect on simplex 4 of the electron transport chain, right? Those 4 phases. It is also part of phase 2 detox, right? Elimination and liver support. I was doing lots of research on this, some just more current studies on this, and they're seeing some really I found a great article actually. I don't know how many of you use Healthline. It's for the public, but they're very particular about what they write. I'm not saying it's all perfect, but they also support with tons of resources. And they had a really great, I'll put it in the chat. I thought it was pretty good. Just great ways to explain and look at glutathione for your patient base. And you can take this. I've already made, patient education handouts and stuff like that for you, but this is also another one. But they had the citation of obviously reduces oxidative stress, improves psoriasis, insulin resistance, which I thought was fun, increases mobility for people with peripheral arterial disease, may help fight against autoimmune disease for obvious reasons. And so there's a lot of different applications for it, although I think in general, we think of it often as anti-aging, right? Skin and complexion. Also anti-aging in terms of cellular health. I'm not sure how many of us do that yet, but that's exactly where it lands. Antioxidant, because aging, in part, one of the biggest factors to aging is due to the oxidative stress that each system allows or is under. And so having a master antioxidant there to balance that definitely works against aging. And then the detoxification components of it. So, you definitely want to do it in light of those things. So we get the question all the time, how do we do an antioxidant with an oxidant like ozone? What about vitamin C as antioxidants and oxidants? It depends on the dose. How do you pair all these things together? And I actually wrote some stacking protocols to answer some of those questions. It's a whole conversation. But first and foremost, you want to make sure it's as fresh as possible in an IV. Second, it should be an IV push if you're doing it well. Third, at minimum, just you can add it to an IV bag, but do it at the end and let it drip that way. And I did do that quite a bit because of just different licensing. In order to do a push, you really in most states are supposed to be an RN. So if you hire phlebotomists, MAs, LPNs, EMTs, etc., they're not technically usually licensed to do those. Although if you as the provider are in the office and train them and teach them, and they follow an SOP, a written SOP for the time, right? How fast. So if I've got 10 mLs of glutathione, saline or sterile water mixture, I'm taking about 10 minutes to push that based on how the patient feels. But all those things should be standardized in your office to make sure that they're being done well. I'm going to take a little bit of break here and see what you guys are writing in. Courtney, what are you saying at SU? I believe it's because the mitochondria are firing and functioning at mass capacity. It doesn't discriminate what type of cell. So nausea and stomach cramping is as common as the chest pressure. Oh, this is for ozone. I get tingling in my hands, tightness in my masseters. Yeah, nausea and cramping, chest pressure, etc. It's body-wide cellular response. That is, it knocked me out when I did. I figured out I did about 40 cc's of 40 gamma the other day, and it hit me from every capacity, which was really interesting. I thought it was a good thing. So if you're giving 10 mLs of glutathione, give it in 10 mLs of normal saline. Yes. Does anybody else disagree with that or have any other protocols to how to do a push? That's just kind of a basic way. I will tell you that the conservative dose, if you, there's just a couple of those simple contraindications to that thiol component as a neurotoxin, and it's a long story. But if you want to be really conservative, you could start with the 500 milligrams. What about doing a glutathione push after a bag of a high doses of vitamin C, like 15 grams? Okay, here we go. 15 grams. Okay, so I didn't make this up. I am not making this up. You need to look into this, but I've been doing this 15 years and it changes. I don't know if science changes or if it's trends change or if it's who's teaching it that changes. I don't know. But 15 grams of vitamin C in my education and years of doing this is not high dose. Some practitioners start talking about, yes, it's close, 18 grams. Paul Anderson, I recorded this with him, says about 20 grams. It starts to get oxidative. And that only lasts for about an hour. You've got to go much higher than that for the oxidative component to be very long lasting. So, but that's okay. If you like the 15 grams, then there's a couple ways to do this. Paul Anderson says, do what you can to keep your oxidative therapies on one day and your antioxidative therapies on a different day. Like really if you know him, and he's great on social media, if you want to follow him, I love his website. He's got tons of free resources and educational materials. And then he has some that are even CME certified. You have to pay for those, but it's still so nominal. I love everything that he does. And he's a great teacher. He's a great, he's a nice, humble man who knows a lot, but his practice is a lot of chronic disease and cancer. And so he likes the oxidative therapies. He told me in that interview, which we lost when we lost SOPMed, we had to remove all those materials, but he told me in that interview that he's done 300 grams of vitamin C. I also worked very closely with Tom Levy for a period of time. He wrote the book Curing the Incurable and a lot of vitamin C data there. And then he was utilizing some of the practitioners I worked with day in and day out to get the clinical outcomes. And review that for even some of his publications. And that was years ago, but just a little background on my experience there. That said, to separate those on different days depends on what you're treating. It depends on what your goal is for the patient, and it depends on where you feel their oxidative stress versus their antioxidant levels may be. And there are some tests you can do to check that out. But if they're coming to you with breast cancer at 35 years old, you could probably bet that their oxidative stress is off the charts. So maybe you want to preload them with antioxidants. And that is the way it's done in Asia routinely, not just for their beautifying effects, but when they want to boost the antioxidants, in before like an ozone therapy or an oxidative therapy, they do glutathione at least a few weeks, glutathione IVs and pushes, at least a few weeks prior to doing any oxidative therapy. You also could do like nano-based or lipid-based, based, whatever, lipid glutathione oral protocols, or my favorite are these glutathione patches. They've been shown to boost glutathione levels by 700% after wearing them for just a few weeks. And they're LifeWave patches, if you're familiar with them. I've talked about them before, but I love their glutathione among some of the others, but this is one of my favorites. I love it for compliance too, because you just wear this little patch and it's a little sticker, and it can boost your levels. So you could do these types of things prior to your ozone treatments or high dose vitamin C. Now, if you do want to do them in IVs together, here's just a general rule of thumb, and you can take it or leave it, although this is my experience in training. You could do 15 grams of vitamin C just fine and do 1, 2, 3 grams of glutathione, whatever dose you're on afterward. The ideal situation would be you would separate them though by at least about half an hour. And you could just wrap up the IV, tell them to go out to lunch and come back. You could, there's ways to do that. The way I love to do it is to hang a bag of saline in between, because the hydration really helps with the ozone, the oxidative stress, and most people are depleted anyway. You got hydrogen and oxygen there that are really part of that cellular cycle too. So that's my favorite way. Do your ozone UV, do at least a 250 bag of saline in between, take about 30 minutes to do that, and then do your glutathione push. Or in that case, that's where you could put the glutathione when you get down to that last like 1 inch of saline in the IV bag, add your glutathione then, and then you can drip it. That's the little tweak I figured out years ago for any staff that shouldn't really be doing pushes, or it can save time if you can catch it right away. But don't mix it with your vitamin C. Don't put it in your Myers bag. In fact, I've seen the worst anaphylactic reaction I ever saw was vitamin C and glutathione mixed together, which is actually the vitamin C that did it. Anyway, long story. But Mitch Genn used to teach that he had seen plenty of patients get hives and different things when you mix the two together. So anyway, don't mix it with your Myers. Do that separate bag of saline. Now here we're talking about saline shortage. That might be a little bit more difficult. And so, you know, if you could just give it some time, depending on the dose of ozone too, ozone's similar to vitamin C. Depending on the dose, it's going to be oxidative longer than at higher doses than lower doses. So again, at 15 grams, I would say that, you know, you're only oxidative there for half an hour tops probably. So then you could give your glutathione. Whose question was about NAD? Oh, the one that you answered, Courtney. Okay, I didn't see a question about NAD, so I apologize about that. Can you please explain why patients get chest pain with NAD? Okay. My favorite, by the way, a little nuance there. My favorite, and I've been recommending this to practices in a lot of franchises, is, if you're not familiar with it, is to do sub-Q NAD. You can prescribe it for your patient. They can do it. They can get the bottle at home. They can inject it every day, just like they would a peptide, just a little tiny insulin needles and syringes. And I love it. I hate getting the NAD IVs. I hate administering them because of all the stuff you're talking about, chest pain and nausea. And now the dose is different, right? So if you're truly using this for, say, drug and alcohol, you know, detox, then that's not what this is for. But man, I love the NAD sub Q every day. You get about 10 minutes of kind of a nice flush and hit. And I notice it when I don't take it. So there are pharmacies that will allow you to order and prescribe it, ship it directly to their house. And most patients would prefer that over the extreme of even 200. 250 milligrams of NAD for me takes me like 3-4 hours. It just, anyway, there's a little nugget too if you aren't already doing that. I've been taught, there's a lifewave.com link. I really encourage you guys to look into it. I think compliance is great. It's sold as a wellness device. It's photobiomodulation therapy. We do have a couple, one or two webinars on it recorded. So if you go to our YouTube channel, you can see some information on it there. It's done by, I interviewed Dr. John Harmon. He wrote a book on what's the blue peptide? GHK, copper peptide. And then this is his second book on epitalon. But he's related or correlated with the LifeWave company. And it is available to the public. So if you've got patients who are already doing it, they can find it other places, but they do have a great setup for you guys in terms of a retail or wholesale, however you want to look at it, aspect to your business. In fact, I was interviewing, what was that, a month ago or so, Holly, we were talking to some providers who bring it into their practice and they localize it. So a lot of orthopedic stuff, and they'll do injections and different things and then send patches home with their patients to put on those sore joints or healing areas because they've got patches that do stem cell per generation and things like that. Anyway, it's a great company. There's a link in there. I've been taught the only reason to do high dose vitamin C and glutathione together is during active COVID infection. Thoughts? You might have to define together. Do you mean in the same, like on the same day? And I would say yes. Active COVID infections, we just hundreds of providers doing those year or two where that was all we were treating, right? Just tons of feedback there. And doing ozone UV, higher doses of vitamin C and glutathione for all the reasons we've talked about and benefits in a very succinct, again, cadence or timing. If they're acute, you need to do it about 3 times a week for a couple of weeks to get the best results and make sure that they don't end up with any long haulers. And that was in that real sensitive phase when it first came out. But you know, I feel like now I don't know what you guys are calling it. I would love to hear this. It's cold and flu season, but now it's like cold flu and COVID season. Like we have a COVID season now. I'm sure you guys are seeing it. It's just, you know, it's like a colder flu season and people are getting tested. I don't understand why the test matters, but you know, how do we treat COVID? It just seems like it's a normal thing now. And that was one approach to bringing up glutathione is there's benefits there. We also created a bundle, right? So if you don't do glutathione yet, or you need some of the tools to help train your staff or educate them on what is good. Like that video presentation I created is great for them. It's like an hour and 10 minutes. It goes through everything at a pretty high level, but also goes through protocols, different applications of glutathione, and then all the implementation materials like SOP, informed consent, patient education, discharge instructions. We put all that together. If you still need those pieces, you're already doing glutathione, but you need those pieces, that's a great reason to buy the glutathione bundle. And it's discounted today for this meeting. But then we also bundled together methylene blue, procaine, and glutathione. And the reason I was thinking is because of the antiviral component to those three is heavy hitters in an IV room. Most people don't realize procaine has antiviral properties. It's one of the best known things for methylene blue. We've seen a lot of great outcomes from that, and you can do it orally or you can do IV, you can do it push. And then adding glutathione to that, because glutathione is that phase 2 detox. By the way, vitamin C is phase 1, glutathione is phase 2. So they do play well together in other situations than what we've been talking about. But yeah, doing those COVID infections are great, but there's a lot of other viruses that fit that same profile. And you know, just really hitting those cells from every capacity. I can tell you, like, just some of my own experience. When COVID first came out, my oldest son got it. We didn't test, but that's what it was. And he was the sickest I've ever seen him. Fever, he was delirious, like it was just wild. And I first did just ozone and UV because I didn't have any vitamins. I had to order it. It came in the next day. So first we did that. He got worse. And I don't think that that's because of the ozone and UV. That's just because that was the trajectory of the condition. And he was even sicker the next day, which was hard to believe. And then I did ozone UV and 20 grams of vitamin C on the second day, and he felt better. Not great, couldn't get out of bed, but it was like, okay, maybe this is taking the edge off. And so then the third day I did ozone, and I always do the high dose protocol, for my family and I, because we've been doing ozone a long time, which is 70,000 micrograms of ozone. And I did 40 grams of vitamin C. And again, I grew up in the world of high dose is 100 grams. So I don't even poke myself for less than 40 grams. But 40 grams. And the next day he went to work. He was like 100%, never had any residual effects. And he was 22 or whatever at the time, 21. So yeah, young, healthy, all those things. But it did really make a difference when we added the vitamin C to it. And I didn't do any glutathione at the time. Just one story that stands out. What about non-allergic reactions, such as palm skin peeling the day after? I've seen that. I think you're referring to the mixture of glutathione and vitamin C, because we were talking about non-allergenic or allergic glutathione, just glutathione. Yeah, I think that that's even in the literature in certain, like, again, where they were using it a lot for skin pigmentation and stuff like that. I don't see it a lot. Other providers can, you know, if you guys see it, that's a good question. I definitely, in years of doing this, you know, 15 glutathione pushes a day. I didn't see that a lot, or didn't associate it a lot with that, but I have seen it in some of the publications and have heard of it. I don't know if that answers the question. Thoughts on glutathione activating stem cells growth factors. So doing MSCs chased with glutathione push. That's an interesting philosophy, Erin. Again, anybody have, I love it, Sienna. I'm addicted to X3949 carnosine. Same here. Same for all of it. All of us MedMaster people, we're like addicted to the patches. We talk about how you can literally almost feel when you take them off, and right before this meeting, we were talking about how to recycle them between kids and animals and how to maximize them. It's amazing, you guys. These things are, and it is a huge company with pro athletes and all sorts of people involved in it. So activating stem cells and growth factors. There are some, I'm trying to draw some parallels here. I haven't seen any direct presentations on that or anything. That doesn't mean they don't exist, by the way. Obviously, I'm not the end all be all. But there is some connection to glutathione and NRF2 pathways. Dr. Purita talked about that for quite some time, and we've had some other presenters on that. And so just cell regeneration. And I definitely can see that with ozone. I don't, it's just, it's such a good anti-aging tactic to do glutathione. I would definitely see the benefit of doing that with the MSCs, but I haven't seen anything directly that's like it actually activates stem cells. And could it be the pathways? Sure, that's why I say nerf 2. I don't know on that. That's a really good question. I'll definitely ask around or let you know if I hear anything. The book, that's a good question. This one is the reverse aging power of epitalon, and it's by Dr. John Harmon. We'll have him on again soon to talk about alpha-talon. He was the GHK copper peptide. He wrote that book too, and it's great. These are written for the public, so they're really great to, anytime I find a book like this, I buy like 100 copies of it. I always ask the patient, will you read this? And if they say yes, I'm like, here you go, free gift, because educating them is always a great way to bring in business. So when I was first getting into this, I literally ordered 100 Curing the Incurable books, so on the vitamin C. And again, I'd put a little gift bag. If they were like, now I'll never read it, I'm not interested, I'm like, cool, no sweat. But if they were excited to learn more about it, I would gift them a book. And I was getting them for like 12 bucks at the time, which is a pretty cheap marketing tool. But I'm a big fan of finding books. The other one I love is the one by Suzanne Fury, Turning Back the Clock, Reversing the Clock of Aging, whatever she calls it. That's another one that's great for you guys and great for patients also. Stacy, I think you were saying on the same day. Stacy, I've been taught the only reason, okay, glutathione together on the same day. Again, yeah, I think it depends on your dosage. And I think that if you separate them, this was a real trend for a long time. I heard people branding all sorts of things, the trifecta, the triad, they would do the ozone UV, the Myers cocktail, and then a small dose, 500 milligrams or so of glutathione. And this was so popular for a number of years. And I think a lot of people got great results from that. But again, low doses, below 20 grams for sure, of vitamin C is also antioxidant. In fact, there's lots of information on that. They have to work together. On the electron transport, no, phase 2, and I can show you guys this. I have the slides right here. The phase 2 detox, right? If you guys could picture this, it actually requires vitamin C, vitamin E, selenium, zinc, manganese. Like these are required cofactors, but glutathione plays a very, very important role in that. So the combo, like I say, they do play well together also if you're doing them as antioxidants or at antioxidant doses. They still play well together in terms of if you increase or oxidative stress, reactive oxygen species, or it already exists, then doing antioxidants is it's redox balancing. That's exactly what you need to do. But if you do them too close together and you want to create that benefit from ozone, and especially higher dose of ozone, then there's a theory they'll cancel each other out, right? That's what we're worried about. So again, it matters as to what you're trying to accomplish in the patient, what the patient's coming in with, and then the dosages that you're using. Where was I at? Do you have any recommendations on adjunct IV solutions with IV plaques therapy? You're talking about phosphatidylcholine? And does glutathione pair well or contraindication? All right. Phosphatidylcholine. I've been kind of on this kick too. Again, single IV ingredient, super simple, does something that nothing else does. So I think it's simple to bring in. I think it's easy to administer. How are you doing it? So I was actually first trained the Patricia Kane protocol, at least when it first came out, was to put it in dextrose. And then so many people, again, I was in oncology too, and in that world, they did not want to give anybody any sugar. And so we got away from that and lactated ringers, saline, and even 0.45. I've seen it done in all of those. Obviously, you need to consider again what we talked about, like, is what's best for your patient's situation. In fact, even on Friday, when we're talking about this is a little bit of a tangent, but we're talking about high levels of compliance and regulatory in IV spaces. The powers that be have definitely latched on to any type of adverse event and even hyper hydration. And there have been a death associated with, IV bars type things. That's not what it seems. But still, you want to make sure that you're doing the right analysis for your patient and giving them the right carrier solution. But I've seen it done in everything but sterile water. Ideally, though, like at first it was dextrose and then it became saline. And I can say I have had some patients, I've seen this. I haven't heard it reported lately, but I've seen some patients where it was not very comfortable going into the vein. But yeah, kind of obsessed with it too. There you go. So you're using D5W. That's exactly how I was originally trained in hundreds that I did originally. And I, are you using the Plaquex? Are you using like phosphatidylcholine from a compounding pharmacy? They might be slightly different. Yeah, the Plaquex brand. Where are you getting that, by the way, if you don't mind sharing it? That's kind of come and gone, and it was a Swiss product there for a while, but it became a little bit tougher to get, and then it became a little bit easier to get on our side of the aisle here. So, yeah, would love to hear your source on that. What was the question though? Oh, yeah. Other IV solutions for phosphatidylcholine. And again, Paul Anderson's protocol was we always paired it with glutathione. So it was 3 consecutive doses, titrating doses of the phosphatidylcholine, and then you'd pair it up with the 3 transitions or titrations of glutathione, 1 gram, 2 grams, 3 grams. Lots of reasons for that. And now years ago, even I was again, the same, functional pharmacist. We had a lot of conversations and theories. They put curcumin with phosphatidylcholine all the time because that makes it fat soluble. And so any vitamin that could benefit from being combined with a lipid is also another, I'm going to throw that out there, another theory that there's other things that you wouldn't mix it in the same bag. They usually do like phosphatidylcholine like the day before. And if curcumin's a sensitive thing too, so don't take that and run with it. But I love the idea of throwing in that lipid component for a standard IV protocol for just about anybody, right? You got the liver component, you got the nerve component, you got the brain component, you got the cell component. We need lipids. So yes, pair it well, but it would be a separate push. Don't put it in the same IV bag. I'm thinking increasing, prolonging BDNF. What is BDNF? I don't know that acronym, Aaron. Hey, Vicky, do you mind finding the links for his 2 books on Amazon and putting those in the chat? The Reverse Aging Power of Epitalon, and then his other one is on GHK copper peptide. Yeah, Amanda, if you want to get back with us on the phosphatidylcholine resource that you might have, I'll do a little more homework on that too. I just did a whole pricing sheet and I believe I got it from Texas Star. I might be wrong on that. Is where that pricing came. I believe they do phosphatidylcholine. I know that Vertisis was doing it there for a bit, but they have had some challenges with the new 797 from well, it's already been a year. I don't know if they're back and running pretty well, but yeah. There's no phosphatidylcholine at Texas Star. Yeah, the brain-derived neurotropic factor, totally agree. And oh, that's right. Anazao, or however most of you say it. That's right. Pharmacy for phosphatidylcholine. Amanda agrees. Oh, Sierra or Sienna, sorry, that's where you're putting yours too. Also, MF plus carries a great phosphatidylcholine. So good. This is why we do this. You guys, we can collaborate, we can get better as a team, better as a group, learn a lot from each other. Um, so doing Plaque X and glutathione on the same day and then titrate both doses up and do them on the same day the next time or 3 Plaque. Yeah. So I would build packages around this. So I would still always do O3 UV alternating, and I would still try to throw in some type of nutrition. And again, what are we trying to treat? But in procaine, if you're doing phosphatidylcholine for any neurological stuff, you definitely want that procaine component. If you're doing it for liver function, you definitely want that glutathione component. Yeah, just thinking through like a true neurological program, definitely want the ozone UV for the anti-inflammatory benefits, the immune benefits, and the circulatory benefits. And in any situation, is there an underlying infection, which is why even methylene blue or ozone UV are a big part of it. But then the Plaque X becomes a piece of that. And anytime we do it, it'd be like, so on your day for Plaque X or PTC, or PC, it's both, right? You're getting the first dose, which it depends on your concentration, obviously, but I was about 10 mLs, 20 mLs, and 30 mLs. That was kind of, Paul Anderson does like 10, 18, and like 26. Like it's a little bit less even there. But I was just 10, 20, 30. And then on that, so 10 mLs of phosphatidylcholine and 1 gram of glutathione. 20, I'm kind of throwing out an idea here, 20 mLs of phosphatidylcholine or Plaque X and 2 grams of glutathione. And then on the third treatment, the 30 mLs of phosphatidylcholine and the 3 grams of glutathione. And once you get there, you would write it out, right? You'd stay at that. I don't know anybody going like intensive doses of phosphatidylcholine. It sounds like a lot of you guys are using it. So if you've got something else to add, but yeah, same day and titrate both of them up each time. And my experience was like, again, like a 500 bag of 30 mLs of PTC could take a few hours to administer. I've also heard plenty of providers are like, it's no problem. And they even do pushes of it. I think that depends on, is it D5W? Is it saline? And then just the sensitivity to the patient's, the patient's veins. Any benefits of using phosphatidylcholine versus methylene blue? I think they're very different. Why would we choose one over the other? I guess for what conditions, Erin? I love them both. Like I would love to get both every month. I was gonna say too, I don't know, I think last month I was telling you I've been experimenting with methylene blue and procaine together, like back to back, not in the same IV, but back to back. And I had good responses with it. I kind of felt like one was an upper, one was a downer almost. And so wondered what that would do, but have had really good responses. Nobody has come back with any like allergic reactions or major detox reactions, or I think that while yes, one like methylene blue methylene blue is so amazing at the electron transport chain. Like it skips simplex 1 and goes all the way to 4 to create energy with less energy. So you should get a boost of energy at a cellular level and then all the way through with methylene blue. And that's why I think of it like an upper. And then procaine, it's like it really helps you like feel relaxed. It's like your glass of wine or perceived glass of wine at the end of the day, coffee and wine. And so I just was like, what do how is this going to go when you put them together? But then if you look at just resetting fight or flight, you look at antioxidant benefits, which methylene blue also is. It seems like in the patients so far, we've done about 20 patients a couple of times in a series, and we've seen really good responses with that locally in the practice here where we've kind of, I don't know if anybody else is doing that, but that is something I've learned a lot more about. Mild mitochondrial dysfunction is what I was thinking, but why are you using PC when it's so expensive and hard to get? I think it's that lipid base, right? Phospholipid base, and how that is utilized differently than the methylene blue. But yes, there could be some crossover too, for sure. Like mitochondria dysfunction, methylene blue all day long. Mold, probably too. Yeah. But phosphatidylcholine, definitely a neurological component. I think that's the, if you go back to Patricia Kane's research, original research and protocol on it, it was for Parkinson's. But again, I would not do that without some procaine or something of the like there too. And also that underlying infection, like you say, like maybe mold, which is where I would go with methylene blue, and also procaine is going to help a little bit, although it's more antiviral, and ozone and UV. Thanks, Vicky. She put the links to his 2 books in there, so those should be easy for you to get. And like I say, we'll get him back on talking about the epitalin. It's much, I think, a less popular peptide, but definitely he's one of those like top experts on it. He just gathered all the research on it and wrote this book. All right, you guys, we've been going a little over an hour. And I am happy to, well, I've got about 20 more minutes till I got a district volleyball game. Super excited. Daughter's undefeated. It's gonna be a tough game tonight, but hopefully that was helpful. We talked about a lot. Again, if you're interested in EBU, write EBU in the comments. If you're interested in DIV or insufflation or both, put that in the comments. If you're interested in glutathione, again, you might already do it, but you need a little help with like refreshing, reviewing. I think it's a great presentation. It pulled together lots of the more recent articles, explain the antioxidant component. And I was initially doing it for kind of anti-aging medicine and regenerative medicine, but the reasons we get sick, if we could slow those down, if we could make those healthier and better, then we wouldn't age as fast either. So they always go hand in hand. But we've got that product, and then this I wanted to say, I added a couple other things in there in terms of detox. And this is just fascinating information to me. Years and years of doing this. How do we help our patients detox? So glutathione's one of them, right? But some of the other things. So we've got the antiviral package of methylene blue, procaine, and all the information implementation pieces. There's a didactic video and even webinars that are associated with each one of those products that we have. And then again, the SOPs, the patient education, et cetera, on, let's say, glutathione. But how else do we look at immune function and helping the body get rid of toxins? So there's 3 additional handouts in there, and you might see that and think I'm crazy. So I wanted to just review them real quick, but I added a couple handouts in. So one is just an overview for patients on immune system. Like, how does the immune system work? How do we keep it healthy? And you could write 10 textbooks on it, right? This is 800 words. So this is that level to patients to help them understand why their immune system is so important, how to keep it healthy. And it kind of leads into these things that you do in your office. So I wrote a handout on that. Then I have a handout on fevers. It's one of my favorite topics of all time. Fevers are so magical, and yet society has been trained that we want to get rid of them as soon as we have them, especially in our kids. We don't have time for the downtime. But what is a fever? What is it doing? That is an initial piece of the immune response, right? And remember that if somebody comes back with a detox reaction that's a fever, what is that saying? That's actually such a great sign. The immune system is recognizing something new. Even if it's been in the body a long time, whatever you've done in IVs, ozone, et cetera, and they get a fever, you have now, it's almost like a vaccine, right? It's like, let's give it a little bit so that the immune system can recognize it and defend it. And so fevers are such a magical thing that we need to allow, we need to understand better, and we need to support. And I wrote a handout on that. And in fact, some of you know this, I owned a practice that was hyperthermia. We were creating pseudo fevers for the same reason. And if if you're at 89 degrees, or sorry, 90, so we're supposed to be at 98.6. By the way, how many of your patients walk around at 98.6? Probably less than half. Most people, thyroid function, et cetera, is lower than that. So their immune system is already impaired. But every degree, 98, 99, 100, and I would love to hear your opinion on this, Sienna, because you're an ER doc, and I've learned a lot from you guys in terms of just your perspective on fevers. But when it becomes dangerous, etc. But we were creating pseudo fevers in people to get their to get that heat component internally to deal with infections, to turn on the immune system, even when the immune system didn't know how to turn on itself. Anyway, I could go down that road for a long time, but a handout on fevers and helping remind practitioners, even your nurses and your IV techs and all those people, like fevers are a good thing. Don't take a bunch of ibuprofen, et cetera, to turn them off. They are a huge part of your immune system. And then also I did a handout. I included it in the detox bundle or the glutathione bundle on ginger baths. I learned this a long time ago, that if somebody's having a detox reaction from IVs, my first exposure was a Lyme disease clinic. And so these Herxheimer reactions were all day, every day. And the greatest thing we could tell people to do is to take a ginger bath. Now, I do it now where it's a mix of hyperthermia and ginger bath, extreme hot water with the ginger. But I don't know if you know this, there are dozens and dozens and dozens of studies that prove that ginger will actually draw from the skin. So oftentimes you take a bath and you do like Epsom salt, magnesium, that's absorbed. If you want to draw things out, and I know there's scrubbing and all this other stuff, but you can simply put ginger in a hot bathtub and you will feel better. So I wrote a handout on that. And these are great tools to educate your patients, help them feel like you know something the regular doctors don't, and to get them to, take accountability and hold of their health even when they're home, and in spite of or along with the IV therapy that you're doing. So it's got those extra 3 handouts in it that glutathione bundle does. That's also why we call it the detox bundle, even though glutathione does a lot of other things. But you can always go in and stir things up, get the immune system firing up real good, get the cells, doing their process, which then is going to create cellular waste, autophagy, etc. And then you got to get out of the body. We all know this. So detox is part of it. That's the other reason why glutathione is so beneficial. And then helping them do that at home. Also getting them on the patches, getting them on some good lipid-based glutathione. It's the only way you can do it. Maybe there is a cream or two out there. I think I put it in the presentation too. I learned of that from Suzanne Puri. So anyway, little extra bonuses there that if you just saw those, like, why would I want this handout on fevers or ginger baths? That's why I put them in there. I think they're really advantageous for your practice and your patients. It's actually fascinating if you look at the world of hyperthermia, such good stuff there in the world of cancer and autoimmune, Lyme disease. I practice hypothermia almost every single weekend in a hot tub. So anyway, all right, you guys, so appreciate your time. Appreciate so much your interaction, your questions. We're going to do this again next month. Let us know if there's any topics or anything you want us to bring up. We'll see what we come up with, and then you'll get some solicitations and emails, obviously, towards some of the other events that we'll be having coming in September. Or sorry, what's after this? November. All right, take care, everyone.